Thank you very much.
And we will move to the next topic. It is a great pleasure to ask our President of the European Society for Pediatric Endoscopic Surgery and our host today, Shiro Esposito, to discuss a procedure for which I had one good trick to be a successful surgeon with that: send the patient to another one. So.
Thank you very much, Paul. My speech will be focused on endoscopic pilonidal sinus treatment. As you know, PSD is a chronic inflammatory disease, occurs in a sacrococcygeal region and occurs mainly in adults or in young adults with a male predilection, more common in men and above all in EPSiT people. There are several surgical techniques described to treat this condition. Also, if you analyze the international literature, there is no consensus about the gold standard treatment option. In general, these patients are treated with the traditional open excision that is maximally invasive because the patients have a painful postoperative course, and in general, the patients, above all the girls, are doubted whether to submit themselves to this procedure, as you can see in this picture, because they have to stay in a prone position in a bed for several days in the hospital, and then also at home they have problems also to recover, and there is a high incidence of recurrence. The aim of this paper is to describe a new technique described in adult patients about 5 years ago, the endoscopic pilonidal sinus treatment that we call pediatric endoscopic pilonidal sinus treatment, PEPSiT, as the drink. In this way, it's easy to remember the name of the technique. Sorry. To perform this kind of procedure, it is extremely important to have a good equipment. You need a fistuloscope, because during this procedure you can have a better ergonomy, and the characteristic of a fistuloscope is that you have an handle that permits to complete the procedure easily. The fistuloscope have a 2 millimeter operative channel, and you have to introduce some instruments, a cautery, a forceps, or a brusher to complete the procedure, as I will show you in the videos. This is the 3 instruments that you need: a brusher, because you have to brush the fistula walls; a grasper, because you have to remove the air and granulation tissue from the bottom of the fistula; and then is extremely important because you have, after the brusher, you have some bleeding. You have to use an electrocautery, an electrode, to perform the hemostasis at the end of the procedure. As for the technique, these are young adults. About the mean age is 15, 16 years old. For this reason, you can perform this procedure in local anesthesia, and the patient is positioned in a prone position on operative table with the buttocks separated by 2 big plasters. You have to introduce the fistuloscope. It's a mini-invasive procedure. You can use the video to see inside, and you can use, to have a good view, saline solution, also if the original technique used mannitol as a liquid to see. Then you have to use the instrument. You have to remove all the hairs. You have to open access. You have to remove granulation tissue, and you have to perform the hemostasis. But you can see clearly the steps of the technique in the videos. This is the fistula. You can enter with the fistuloscope inside. As you see, you have a very, very good view. You can identify the fistula's trajectory. Sometimes there are abscesses that you have to open, and there are several tracts. Then, as I told you, the original techniques use mannitol. We use saline solution without problem. You have to identify the air that you can identify and then remove thanks to the 2 millimeter forceps. You have, thanks to the fistuloscope, you have a very good ergonomy and a very clear view. Then you have to perform the hemostasis because you use the brush on the wall of the fistulas. You can have a little bleeding, and is extremely important above all for the postoperative period. You have an electrocautery and you have to cauterize the fistula walls to avoid bleeding. And then you have to remove the granulation tissue that remain inside the fistula. The disadvantage of the technique is the same of one trocar surgery, because you have the optic coaxial instrument. For this reason, you need laparoscopic experience to perform this kind of surgery. And then, as I told you, sometimes there are several tracts, there are abscesses. You have to identify the main tract, as you can see in this video. Then you have to identify if there are other tracts. As you see, there is another tract here, and you have to treat in the same way. It's extremely important to do it to avoid recurrences. And at the end, you have to remove the residual air from the bottom of the fistulas. Thanks to the use of saline solution, you have a clear view for all the procedure. For this reason, is easy to perform. As I told you, this procedure is linked to the instrumentation. And then at the end, you have to perform the hemostasis with the monopolar electrocautery, and at the end of procedure the external opening was not closed. And the main advantage of this technique compared to the standard procedure, the patients kept a normal decubitus and the hospital stay is very, very short. As I told you, the external opening were not closed. As you can see in this picture, there are in general 1, 2, maximum 3 openings, and at the end of procedure we apply a dressing on the incision. During the postoperative period, the patients kept a normal decubitus. We use no drain. In open surgery in general, we put 1 or 2 drain. Patients have little pain, and the hospital stays is very short, maximum a couple of days. Our personal experience is until now 18 patients. The main age 16 years. As I told you, the majority of patients are boys, and all presented with acute or chronic pilonidal sinus fistulas. And sometimes there are patients that recurred that after open surgery. We operate a young girl operated 6 times in open surgery with the recurrence of a fistula. For sure, as all the surgical procedure, patients seen informated consent and their parent before surgery. As for the result, the length of surgery is very short, less than half an hour. In our preliminary experience, we have no intraoperative complication. We analyzed the pain with VIS pain scale that ranges 2 to 5, and the median was 3.2. The analgesic requirement is poor. In general, we give only paracetamol every 6 hours for the first postoperative day. The hospital stay is very short compared to the hospital stay of the classic treatment, that is 5 days, 1 week. The follow-up is maximum 1.5 years, and as you can see in the picture, the patients recover, and at the moment we have no recurrence in our experience. In conclusion, our group believed that this technique probably represents the technique of choice for surgical treatment of pilonidal sinus in children, because it's easy to perform and it has a short and painless hospital stay. with a low rate of recurrence. We have no recurrence at the moment compared to the rate of recurrence of standard therapy. And I think is a key point. You need a fistuloscope to this because the handle of fistuloscope is very important for the ergonomy of procedure, and for this reason we need an adequate instrumentation is the key factor for the success. I think that this technique allows to the patients to return to full-day activity rapidly without restriction, because with the open technique the patients stay prone at home for several days. For this reason, with this technique they keep a normal decubitus after surgery. I think that mini-invasive surgical experience is necessary, above all for the management of the operative optic, and it's the same for the fistuloscope. Learning curve is short. This is a preliminary experience, and I think that a larger series with a long follow-up are needed to confirm our preliminary result. And I would like to invite you in Naples next year. We have an international training center with the endorsement of ESPES, IPEG, EPSiT, and Italian Society. And next year we will organize the classic neonatal course, urologic course, and also the robotic one. I would like to thank you for your attention.
Very nice and innovative technique. Do we have questions from the audience?
Yes. There are some questions from Nicholas Dimitrios from Greece. Congratulations for a very interesting presentation. Do you think that the use of fistuloscope is essential to perform this technique, or you can use a simple cystoscope to do it?
Thank you for this question. It's extremely interesting. We're starting this procedure using a cystoscope, but the view is not the same because the fistuloscope has two main characteristics. First of all, diameter is a little bit larger, and then you have the handle, because one of the limits of this procedure is the ergonomy. For this reason, thanks to the handle of fistuloscope, you have a very good ergonomy. And then you need all the instrumentation. You need mainly 3 instruments to perform this procedure: the brusher, grasp as forceps, and an electrode. I think that as in laparoscopy, this technique is linked to the instrument. For this reason, you need the fistuloscope to do this.
There's some other question. Carla asks, how many recurrences after surgery in your experience?
As I told you, this technique was described by adult surgeon, Italian surgeon called Maniero, and in his experience with more than 200 patients, I think he has less than 2% of recurrence. In our preliminary experience, we have less than 20 cases with 0 recurrence, but I think that we need more data. But we started an Italian multicentric survey to have more patients. But I think that compared to the standard open treatment, the incidence of recurrence is extremely low.
Another question again, this interesting argument. Kirkus Korjeska from Poland asks you about, is there a higher rate of complication using this technique comparing with open repair, and which, above all because of which the learning curve of this technique?
I think that one of the limits of the open technique is that sometimes we leave a drainage because we have some bleeding. For this reason, in a drainage for 1 or maximum 2 days. With this technique, you have a very good view. For this reason, the hemostasy is essential to reduce complication, because one of the complications can be to have a little bleeding. For this reason, thanks to the magnified view of a fistuloscope, you see very well. To avoid recurrence, you have to identify all fistula tract, to have to cauterize that. You have to identify all the hairs that you can find, and you have to remove it. But as I told you, and I think it's clear in the videos, the cause of recurrence is that you leave some air or granulation tissue inside. For this reason, it's extremely important to clean the fistulas at the end of procedure and to perform a good hemostasis to reduce complication rate.
More question again. Alvaro Costa from Portugal asks you again, as for the postoperative course of patient operated for pilonidal fistulas, is there any difference between classic and open repair and endoscopic repair, according to your experience, if you have operated?
Yes, good questions. I think one of the main advantages of this technique is the difference between the postoperative course after standard procedure and endoscopic procedure. Patients operated with a standard procedure have to stay prone in the bed for some days in the hospital. Sometimes we give them loperamide to avoid problem with evacuation. And after at home they have to stay prone. Sometimes there is dehiscence of the skin suture. I think the main advantage is that after endoscopic procedure, the patients stay in a normal decubitus, stay 1 maximum 2 days at the hospital and no problems.
A practical question from Fernando Montes Tapia. He asked if it's possible to see again the video of PEPSiT, in which way?
As for the masterclass will be on YouTube I think in a couple of days. You can see again all the presentation and all the videos. This masterclass is in a live streaming. For this reason it's difficult to re-show things, but you can find all the masterclass on YouTube on a couple of days.
Ashraf from Egypt asked if do you perform any preliminary diagnostic tests that need to be performed in young patients for this treatment?
No, we perform only clinical evaluation, no instrumental tests. As I told you, we operate some patients that they had operated with standard procedure and they recurred, and I think we have all in these patients good results. But as for instrumental workup, preoperative, only clinical examination.
There is another question, last one. Alina from Moscow asks you if for you is the first is best for the first procedure or for the relapse, this technique? Is first line procedure or?
Yes, now I think is the first line procedure because is extremely easy to perform. You need the instruments to start this. I start, as I told you, with the cystoscope, and then I tried the fistuloscope, and it's completely different. But I think it's a first-line procedure. I think that probably now the standard treatment can be abandoned because it's completely different, the technique and the post-operative outcome and then results in the first line, absolutely.
Sorry. Thank you, Ciro, for this innovative procedure. And if the results are confirmed, I think it's a revolution, because the results are amazing today. And I would want to see you, and I would want to show me how to do, because it's very, very interesting. My question, when you have an abscess, the first step is to empty the abscess, to treat with antibiotics, and after to do the procedure, the video procedure?
Yes, if there is an abscess, we treat before operating an antibiotic therapy, we open the abscess, and then after 1 week, 10 days, we operate using endoscopic procedure, and we remove the residual tissue. And thanks to the irrigation with saline solution, we can wash all the abscess wall and remove the granulation tissue. But before starting, it's preferable to treat with antibiotic treatment, opening the abscess.
And to have a sponsor, is it possible to wash with PEPSiT?
Or with Coke?
Yeah, Ciro, I was very interested in this technique. You are always just pointing little nice things. I will try to do that. But just one point was the same about the abscess. I think could be safer to put a little drain when there is an abscess, because the risk of some recurrence of infection is almost high, although you are grasping all the ground tissue down there. And the second little point, we have to do the same thing that we used to do in open surgery. In open surgery, we used to do till the bone of the coccyx. Do you go there? You go till the bone?
As for the abscess, probably, as I told you, it's preferable to treat the abscess before, because with the abscess inside, sometimes you have not a very good view. And I think the key point of the success is to have a good view during all the procedure. And as for the coccyx, we arrive with the endoscope until the coccyx, where there is the end and the bottom of the fistula. You can arrive, we can treat, we can remove air, and we can coagulate. We can follow the fistulas until the end, as in open surgery.
Well, is there any other question, comments from the web?
There are one more question from Carla that asks if do you think it's possible to increase the result after cauterization of the fistula using glucose or some other sclerosant substance?
We have no experience. We use only monopolar electrocoagulation with a 2 millimeter electrode, and as I show you in the video, we have a very good view, and you can cauterize all fistulas without problem, but I have no experience with other devices. So.
Then if there are no more questions from the viewers, I'll take the privilege to ask you two little questions. You mentioned the bleeding, but is the coagulation electrode electively stopping the bleeders or trying to erase the entire wall of the tract? And the second, do you have any experience of multiple openings? And would you put the scope in different positions?
First of all, if you use the brusher, there is a little bleeding. For this reason, first of all, you have to treat electively the side of the bleeding. Then I prefer to treat all the fistulas wall. And sometimes, as I show you in the video, there are different tracts with different orifices. I put the endoscope in all the orifices. Sometimes there is an orifice up, an orifice down. I put the fistuloscope in all the orifices, and we treat the different tract in the same way. And we leave open the orifice at the end of procedure.
Well, thank you very much. No more questions, no more comment?